going to talk to you.
Oh, yeah.
Do you remember?
Okay. Well, good afternoon, everyone. My name is Erica Traffel. I'm one of the associate directors here at the Prevention Research Center for Healthy Neighborhoods. So I want to welcome you to our monthly Wednesday seminar. Glad that you all can join us. Today, we have Dr. Dana Prince, an assistant professor from the Jack Joseph and Morton Mandel School of Applied Social Sciences. How often do any of us say it all out loud? I challenge myself today. And she will be giving her talk, Community-Grounded Research to Address Mental Health Disparities of Sexual and Gender Minority Youth Touched by Foster Care. I'm really excited for this presentation and wish I had more time to talk with you separately, but we'll set that up. Dr. Prince, prior to coming to CASE, completed her NIDA-funded T32 postdoc at the Yale School of Medicine in 2016. She's developed a robust program of health disparities research that focuses on the transition to adulthood for vulnerable and marginalized youth, most notably substance use, incarceration, and homelessness among adolescents and young adults transitioning from foster care. And subgroups of youth in foster care, notably sexual and gender minority youth, face additional risks. And so SGM, or sexual and gender minority youth, is the NIH-designated definition for individuals who are a sexual minority. But this includes both sexual identities, such as lesbian, gay, bisexual, and or have a minority gender identity, including transgender and gender nonconforming, which we'll hear more about in this talk. And Dr. Prince is currently involved in 2 federally funded research projects focused on sexual and gender minority youth in foster care. And so I'm particularly excited to introduce Dr. Prince. Before we do that, though, we're going to have Morgan Taggart, who's a member of our network of community advisors here, just give another welcome, and then we'll start our presentation.
Hi, everyone. I just wanted to say hello and welcome everybody here to the seminar today. I am the co-chair of the Network of Community Advisors, which is an advisory group to the PRC here at Case Western Reserve University. We're a group of community stakeholders, partners, residents that help guide the research, design of research projects, and also the dissemination, getting these results out into the community. So we work hand in hand with the PRC here. I've been on that committee for the past 9 years and really enjoyed the partnership as a community partner with the research institution like CASE. So welcome. If you have any questions about NOCA or the work that we do, please feel free to ask. I know Lakita's here from our core modeling team. She's on one of our research projects here with Dr. Darcy Friedman. So just wanted to welcome everybody. I'm very excited about this topic as a former foster care parent and learning more about these disparities. My focus is on food and health, so I'm really excited to learn more about your research. So thank you for being here today.
Yes, thank you.
Yes, welcome, Dr. Prince.
Thank you. Thank you. Well, it is wonderful to be here. Thank you for having me. And before I get started with my talk, I'd just like to get a sense of who's in the room with us. So if you can raise your hand if you are a student, a graduate or professional student. Great. And are you in the health sciences, medicine, nursing, social work? Social work. Biostats, awesome. Okay. Can you raise your hand if you are a faculty member or researcher here at the university? Okay, wonderful. And if you are in the community, if you are a service provider in the community, working in nonprofit, working in community organizations, where do you work?
In the Center for Community Solutions.
Wonderful, yeah.
Planned Parenthood.
Planned Parenthood, awesome.
The Food Trust.
And the Food Trust, okay, great. And if we have any community members, community activists, organizers, awesome. But I'd like to welcome all of you into this space for this conversation. This is a conversation that really is something that touches on every single sector of who's in the room, right? So researchers, academicians, scholars, community members. It's a complex problem that's going to take a lot of us to be able to figure out and solve. And so my goals for today, for our talk, is one, to just present for you a picture of what mental health looks like for sexual and gender minority youth nationally. I'd also like for you to understand what that looks like for the intersection of sexual gender minority youth who are involved in foster care. That's a unique group that's at additional risk of negative outcomes. I'm going to understand a theoretical model that I use to guide the project that I'm talking about today. It's adapted from Myers' minority stress model. Are any of you LGBT researchers in the room? All right, so that's fantastic. Maybe by the end of it, some of you will want to be. We're also going to understand how this pilot study is embedded both within the community, within community-based organizations, within queer people who are reaching out to their networks to pull folks into this, and is also embedded in system. And I separate that out for very particular reasons. So I work in the foster care system that is directed by Cuyahoga County, that has a whole set of norms and mores and practices around it. And it's very important to be able to work within that system. That system is very different from working in a community-based setting and doing community-based research out of a center, even Planned Parenthood, right? Those are very different contexts. And this research really pulls folks to the table who are community activists and who work in DCFS. So it's a unique team. I'm also going to talk through 2 examples using current data that I have from a pilot study that is active at this time. It's only been active for 2.5 weeks, so our sample size is 5. All right? So bear that in mind. But even with those 5 participants, I can show you how we are adapting measures to be culturally appropriate, to be trauma-informed, and to be affirmative of sexual and gender minorities. I will show that to you in the data. And then finally, I really want to talk about how a trauma-informed approach can be applied to research with vulnerable populations, and that's especially critical for youth who are in foster care and for sexual gender minority youth, and even more so for that intersection, again, because we have youth who have been traumatized and re-traumatized throughout their experiences in foster care, and also the stigma attached to their identities. The big take-home I'm going to tell you at the front end of this is that the issues for sexual and gender minority youth are not about them. It is not about the individual. It is about how we as a society and a system treat the individual. So this is not a pathology model at all. When I talk about psychological comorbidities, suicide, depression, and anxiety, that is not pathologizing SGM young people who have those struggles. That is about understanding how those psychological comorbidities and the burden of them in this population stem from society and culture and stigmatizing interactions and discrimination. Okay, so that is the frame going in. But before we can go any further, and because I know the room may not be full of SGM or LGBT researchers or individuals, I also claim that I am also a sexual minority myself. So this is a population that not only I work with in terms of my research, but that I have been out and in the community since I was 15 years old. So over 20 years, to date myself. But language and definitions 101. There are a lot of really wonderful pictograph kind of things like this that you can easily Google if you want something like this for your classes or for groups that you work with. First takeaway is the sex that you're assigned at birth does not equal your gender. This is the biggest one for those of you that have never heard that before, that might be like, what? But this is the biggest take home. Sex does not equal gender, okay? Gender expression is how a person expresses their gender in their day-to-day interactions. So think about the clothes that you chose to wear this morning. Think about hand gestures, voice inflection, all of those things that express gender. Sexual attraction or orientation is different from gender and different from sex, right? And so this is who a person is sexually or romantically attracted to, right? And then romantic or emotional attraction is sometimes teased out even further, especially in younger queer folks, 12 to 18 population, who are more and more identifying as asexual or ace, but maybe pan-romantic, which means that they don't feel a sexual attraction for a partner, but they want an emotional affiliation, a romantic relationship that doesn't have a sexual component. All right, so teasing apart attraction from the emotion piece is really tied much more so to this age cohort that I work with. Any questions about this before we go further? Because we got to have just a base. Yes?
Is this general for any human being?
Correct.
But the sex assigned at birth, you say it's not necessary, but it could be your gender, hopefully.
Well, I don't know if I would say hopefully. I would say that yes,
I
this.
like what I am.
Right, so you have a sex that you were assigned at birth that matches your gender identity, which is your cognitive self, how you feel about yourself, which matches onto some sort of societally prescribed idea about what that should then look like, wear, act, behave. So absolutely, everybody has all of these things, and they can map up in any kind of way, right? Yes?
So can your gender identity, I assume this is yes, but I want to make sure I'm right.
Yeah.
Your gender identity can be different from how you choose your gender expression to be.
Correct.
Yeah.
Exactly. And so this becomes super important, especially when we think about pronouns, which might be something that some of you are familiar with. I know in our classes at MSAS, at the Mandel School, our practice now is in introductions to always ask, what are your pronouns? And I always introduce myself by saying, I'm Dr. Prinz, my pronouns are she, her, and hers. And that signals to folks in the class that this is a space where they can also identify their pronouns, and that I'm not going to assume, based on how you outwardly appear, that that's how you inwardly identify. And that's also affirmative practice with this population. So it's something that we've woven into all of our procedures and protocols for the pilot study about how we do the most simple things, from if you've done research and you know you have a telephone call, right? You're following a script to call a participant to see if they want to participate in your study, maybe, or sending an email. These are sort of standard practices. Part of that script is to say, hi, I'm Dana, I'm the researcher from Case Western. Hi, I'm Dana. My pronouns are she, her, and hers. I'm the researcher at Case Western who's doing the study on foster youth. So it's right there in the script. Usually we just say our names. When you're working in this population, we also say pronouns as part of affirmative practice and weaving that in. So I'm going to hold off on any more questions about this, because I'm also going to show you through some of the data what this looks like on the ground, which may then help answer some of those questions, and we can always revisit that at the end. So the first thing that I'd like to briefly give you a snapshot picture of is psychological comorbidities, suicide, anxiety, depression, among sexual and gender minority youth nationally. So we know that a third of this population is at increased risk for a major psychological disorder. 15% had major depressive disorder. And recent and meta-analyses that have looked at all the studies on suicide that have been done in this population to date, we find an odds ratio that sexual gender minority youth are 3 times more likely to report suicidality than their heterosexual counterparts. And the odds ratio is actually even higher for bisexual youth, which points to the fact that we need to be able to look at differences within this very diverse population, which presents unique methodological challenges when we're working with small numbers. And that's something I'm not going to go in depth about today, but if you're interested in that, that could be a separate conversation. Okay, so we also know transgender and gender nonconforming youth also have elevated rates of internalizing and externalizing disorders and suicide, and that actually some more recent research has shown that that association is fully mediated, so completely accounted for, by victimization experiences. So this is again highlighting that kids aren't depressed because they're gay, okay? They're depressed because of how society and parents and peers and teachers treat them because they're gay, all right? So this is the non-pathologizing kind of framework and that shift. But historically, when we look at LGBT health, it's been all about pathology. That is the history and legacy that we have. And so it's a constant reframe to understand what are all these factors that are making that happen in a young person. It's not about that kid, right? These recent statistics from national data, 82% of transgender youth report feeling unsafe at school, 44% of them report being physically assaulted in the last year, and 83% report being physically harassed at school. Really staggeringly high numbers. Okay? And that's chronic, right? That's not this one time. That is chronic, repetitive, daily insults and assaults. And that slowly over time, we know that those experiences accrue over time and impact the kid if there aren't these other supports in place. We also have, I think of things a lot like multiple layers, okay? So those are interactions with peers. Family rejection is another big issue and contributor to depression and suicide in this population. We also have systemic society level things. And so there's some really newer, interesting research that looks at policies and that's what, and laws, and if living in states that are more inclusive, that have protections in place, accounting for all these individual things, that those state level factors actually matter on adult health outcomes over the lifespan. So it's thinking about these things up and down levels. So what about sexual and gender minority youth in foster care? So this is the group that I work with. This is where all my work is located, my project with DCFS in the community here in Cuyahoga County. It's at this intersection. It's not just sexual gender minority youth, it's those who are in the foster care system or have been in the foster care system. So the first thing that we know is that these kids are overrepresented in our foster care systems. Estimates range from 18 to 60%. That's a really wide range. The 60% is coming from the Bay Area. I saw your face. Yeah. So one of the things that's super critical to understand here is that these estimates are based on discrete populations. They're not national estimates. Why? Because systems don't capture this data. We do not ask kids about their sexual identity or their gender identity at any point in intake, in case management, in placement planning. We don't ask for that at the system level. Now, one of the grants that I'm part of, Cuyahoga was selected as one of 4 national implementation sites with a 4-year grant from ACF, so it's federally funded. And what we're doing as part of that is actually developing safe identification policies, practices, and procedures here in Cuyahoga County to address that issue. And it's a big issue and a complicated issue, not one I'm going to talk about today, but it's important because, as I tell people all the time, if you are not quantified, if you are not literally counted, then you literally don't count. You don't exist. You don't exist. And so we have to be able to capture these numbers to understand who it is that we're serving, and also to make sure that they're then being linked with appropriate affirmative caregivers. I see you have foster care, right?
Oh, yeah.
And all these things. So we do know that involvement in foster care in general. Foster youth are at heightened risk for psychological problems. One study found they're 4 times more likely to commit suicide than the general population. And then we also know from some of the studies that have happened in like New York and other places that sexual and gender minority youth experience greater placement instability, longer lengths of stay, and more restrictive care settings than their heterosexual peers. Those are a big deal. If you're a child welfare person, if you are familiar with the foster care world, we know across the board in the general foster care population that these things, placement instability, that means 15 moves, 16, some of the kids I work with, 21 different placements over the course of 5 years. The increased placement instability is one of the most significant predictors of adverse outcomes, both while you're in care, but also that transition out. Homelessness, substance use, incarceration. We also know that longer lengths of stay and more restrictive care settings. So not being in a foster home, but being shoveled into congregate care and residential and these group home settings, that is worse. So our queer kids are getting more and more of that. And we know that that's not good, right? And they also face rejection and stigma both from biological family networks and also from foster families. So there's this additional compounding of caregiver rejection. Some of our kids who are SGM are in foster care because of their sexual orientation. That's literally why they are in care, right? And some of them are coming out while in care and then faced with rejection when they do, or they conceal their identity because they're afraid they're going to get kicked out of another home.
Just a really quick question.
Yeah.
The project you're doing with DCFS, are you working with the juvenile court as well?
Not yet, but we're working on it.
Because they're one of 3 counties that are collecting the data.
Yes, yes, I'm on the, yes.
Okay, great.
I'm on those
Just
phone
wanna
calls.
make sure.
Yeah, we missed the boat,
Unfortunately.
yeah,
okay.
but maybe we'll get on the next, yes.
Okay.
Separate conversation, but yes, we can talk about that, and we're working with Equality Ohio.
Okay, good.
I have a call with them on Friday. Okay, so if you're not familiar with Cuyahoga County Division of Children and Family Services, this is our service area. We're the 2nd largest county in the state. The county surrounding Columbus, which I always forget the name of. Franklin. Thank you. That's bigger than us, but we're still pretty big. So we had just over 20,000 child abuse neglect referrals in 2017, and in 2018 there were 2,300 children in care, so it's up 40%. So that's just a snapshot of where we're looking. So I want to now focus to talk specifically about this pilot study. So I mentioned the larger grant, the 4-year grant through ACF. This pilot study was an opportunity to embed deeper data collection on a variety of things that we couldn't collect in the big study into a smaller pilot. It's funded by the Center for Reducing Health Disparities through their mechanism for early career investigators that are working with communities to address health disparity population. My partners on this are extensive. So we're partnered with DCFS, Division of Children and Family Services, the LGBT Center of Greater Cleveland is a partner, Connect is one of our partners. They are a nonprofit social service organization that does a lot of subcontracting with DCFS around permanency and family finding and more innovative child welfare kinds of interventions that are really about stability and connection for kids. So they're on this. And then A Place for Me, which is a program out of the YWCA that's focused particularly on young adults experiencing homelessness. The majority of those young adults have also experienced foster care, and then there's a subset within that who are also LGBT. So there's a lot of partners on this. This is a novel study in that we are actually looking at that intersection of sexual gender minority and foster care. No one else is doing this in this way. It's community and system embedded, and it's mixed methods. So we're doing these surveys, we're doing focus groups. I also have administrative data. So what I'm asking young people to do is to consent for me to use identifiers to access their SACWIS data, which is their state child welfare data. And that has all the things about the number of placements they've been in, the times they've moved, restrictives of care, all of those different system level sorts of variables that are very, very important to understand, but that are really bad if you try and get self-report on. So that's an additional layer to this, is the administrative data, the self-report survey data, and the focus groups. This is the first aim of the study. So we're collecting 100 surveys between now and June 1st. And if you are in this room in the position of being at like an agency, I might contact you and say, hey, do you want to recruit some folks for this? So the first aim is to investigate the relationship among stressors, those related to foster care involvement, early adversity, and victimization, with suicidality, depression, and anxiety among this cohort of sexual and gender minority youth ages 12 to 26 in Cuyahoga County. And then I'm also looking at some theorized sort of protective factors. One of them is social support, caregiver acceptance, and then future expectations, and to see if that's higher among the population. Does that offset? Does that dampen the relationship on outcomes? And then we're also doing qualitative focus groups, 3 with youth ages 12 to 17, 3 with youth ages 18 to 26. And those are really digging much more deeply into the idea of social support, which is known to be a protective factor for foster youth. However, we don't know what it looks like for LGBT foster youth, and one thing I'm very concerned about is how LGBT foster youth don't access biological family networks the same way that other foster youth do when they leave the system. Why don't they access those biological family networks? Because they're LGBT. And how does that then play out in what we see in terms of survival sex and other kinds of things that particularly trans feminine for foster youth have to do to be able to live. So we're going to be looking a lot more at that issue and trying to understand it from the youth's perspective, and that will help us to inform service delivery. Okay, how are we doing so far?
Good.
We're good?
Yeah.
All right. Okay, this is my... What, depressed? No. We're going to... All right, yes. Okay, yes, it is depressing, but it's also so important, right? Like, that's why we're here. That's why we do the work. This is my like 30-year program of research, right? Like, I'm not just doing this to get a pilot study and to publish some data. Like, I am doing this work because I plan to be here in Cuyahoga County working on this issue for a long, long time, and connecting with, right, and connecting with all the other service providers that we have to provide that network of safety and support for our young people, because we actually can do it. We have so many resources here between the hospital system, between all the different systems that we have. We just have to figure out a way to play nice together in a very challenging funding environment. and be able to make that work. So yes, depressing, but no, that's not the end game.
Will you have Q&A later?
Q&A later? Yes, I hope so.
Yes.
Depending on how I'm doing on time, I tend. Okay, yeah. I'm going to just go through this briefly because I think that theory is really important and should guide research and practice. And this is also a visual model of everything that I'm looking at in this pilot study. So this is, again, adapted from the minority stress model, which is a model that Meyer developed to explain why do we see disproportionate rates of anxiety and suicide, depression, and other bad things in LGBT individuals. And this model's been tested mostly in lesbian, gay, bisexual. More recently, folks have been looking at it in transgender populations. It's been more looked at in adults, less looked at in youth. It's never been looked at in SGM youth and foster care. So that's what I'm doing. And the way that I'm then operationalizing this is it's a general stress model. Okay, so it's basically the idea here is that there are stressors that stack up that a young person experiences, and the more of them that stack up, the worse the outcome. That's the basic concept of it. So we have kids that are in out-of-home placement. So they've already been removed from a home. That's a stress number one. It comes with a lot of different kinds of things. There's general stressors that they may then experience as a result of being removed from home. Things that I've talked about. Placement instability, they've experienced child abuse or neglect, number of removals, restrictiveness of the care setting. Then within that, they also might experience stressors related to being LGBT or being perceived to be LGBT. And that has to do a lot with victimization experiences, caregiver rejection, and discrimination. Then there's this proximal stress process, which is how those experiences of discrimination that happen in the world are then internalized inside of a young person. Right? So that's where we see expected future rejection. If I'm rejected a lot in the past, do I then expect to be rejected in the future? If I expect to be rejected in the future, that's going to play into this psychological comorbidities. Concealment. So this is a strategy that many young people adopt, particularly in foster care, about hiding their gender identity, making sure that they've changed out of female clothes and washed off any makeup before they go back, because if foster mom sees, they don't want to get kicked out. And concealment over time, this is a stress coping technique. In other populations, stigmatized populations, we know that concealment over time leads to poor mental health outcomes. And then internalized homo and transphobia, right? Internalized homophobia, internalized transphobia, how those things over time kind of erode sense of self and well-being. So those are the main stressors at these different levels that I'm capturing in the study. And then we also have how they identify. So there's a variety of questions about self-identity that I'll discuss. And comfort with identity, pride in identity, which could be protective as well. And then in terms of the moderating factors, we're looking at social support, caregiver acceptance, and future expectations. I went over that kind of fast, but yes.
I know we should wait to the end, but just while you have this up,
Yeah.
I would love if you would take this and do what you did with the framing, and then do the interaction with the larger societal factors once, because this is very individual.
Yeah.
The way you framed it doesn't come across at all. So that could be your next paper. I mean, that would be a real contribution, just have that framing around this. So you just have the arrows to how this is all caused by the society.
Can you make this is my partner, Rowan. They're here as my emotional support person. Can you write that down, baby? Because I won't, that's a great idea, and thank you, and I won't remember, but Rowan will remember. Oh, and it's there. Now that's also on tape. That's perfect. That's awesome. Thank you. Okay. So, going now into this pilot study, I'm going to talk just a little bit about the pilot study and hit some key things that we're doing that are unique and keeping it affirmative and trauma informed. So first of all, this study was community engaged from the conceptualization through implementation, and it will still be community engaged when we're looking at the data and making meaning of the data with all the community partners, and then creating things that are useful to all the partners around that data. So because it's, my currency might be manuscripts, but the LGBT Center's currency isn't manuscripts. So how do I then work with them to create results that are meaningful for them, writing things up and having nice, graphics and things like that they can take and plug into grants. Right, so those are kind of the things I think about with the dissemination piece. We are also affirmative and trauma-informed in our study instruments and procedures. And that might seem like very basic things, like how we introduce ourselves, always using our pronouns. There's a lot that is embedded in the study protocol. I will show you some of that about how we are affirmative throughout the study protocol and the language, how questions are phrased. A key phrase we use a lot is all pathways are valid. We use that a lot after a lot of the questions, and that's an affirmative phrase that's used in other transgender research in particular. Also being trauma-informed, and we have a diverse study team. So in terms of who is collecting the data, this is my team of data collectors. We know from other research with racial minorities in particular that race-gender matching really matters around self-report. And so trying to find a way when young people want to be able to say, we have great interviewers, here's some of them, do you have a preference? Right, so being able to offer, we have a male-identified Latino gay man. We have and it's a little awkward feeling at first when you're like, I'm listing this list of identities for you, but actually the young people really liked it. And some of them have had preferences and some of them haven't, but they have a choice in kind of who they maybe want to talk to. Okay, what's next? In terms of the community and system embedded piece, there's some highlights that I will talk about. So the system embedded is at the top. We have DCFS and Connect. These are also both partners on the larger 4-year grant. Within DCFS, when you're interviewing a young person who's under the age of 18 and in custody of the state, the person that you get consent for is not the foster parent, it is the state. It is the supervisor of the case manager working with the young person. This is part of the reason why people don't do research in this area. It's very hard to get access to those kids if they're in custody. So you have to go through all of these layers of bureaucracy. So I have, on the study team, I have 3 DCF supervisors. They are also, at this point, great friends. They are all trained in CREC and City Basics, which is what we have to do to be IRB approved, to be able to conduct research. And they are the ones who consent kids into the study by talking to their supervisors, right? So I'm not going down to DCFS and trying to find a supervisor and say, hey, I hear this kid, might be interested, a good fit for this study, can I talk to you about it? They're doing it from within. And they're all same rank. So there's no one above rank trying to consent someone below rank, right? Does this make sense? Okay, so that was a process. What I want at that point is like a wow, because honestly, that was months of my IRB life getting that in place, all right?
I'm doing the math from your postdoc, and I'm like, how have you done all of this?
Blood, sweat, and tears. No, ask Rowan.
I'm impressed.
Okay, so that's a key piece, because then also how do we safely identify those young people, right? Because those 3 DCFS social work supervisors who are on the study team, who are IRB approved, who have gone through their correct training, they know all the caseworkers. And so when a young person maybe is identified, they know which caseworkers are cool, they know which caseworkers may not be so cool. So they know how to navigate within that. So when they're approaching a young person, they're not outing them. Super important, right? So there's a lot of sensitivity in doing this work within a system and needing to have people inside that system who understand that system, who are trusted in that system, who can work with you around the recruitment piece in a way that's going to protect the kids, because that's what it's all about, protecting the kids. In terms of Connect, in the larger grant, they have a caseload, an active caseload, because we're developing, testing, and piloting an intervention, a permanency-based intervention for LGBT kids in foster care. That's actively happening, so they have an active caseload, and so those young people are also being referred to us through the same similar kinds of mechanisms. And because they already have these relationships with the young people, they reach out first, similar to our caseworkers. They reach out first and say, hey, we work with Dana, she's doing this study that you might be interested in, is it okay if she contacts you? So they have a known person as their first contact, followed up by me. But what's interesting is that a lot of the times the kids will talk to me once, but then they'll keep talking to the person they know, which makes total sense. So if I'm not talking a lot with Mary, then I don't know where so-and-so is, And so then I work with Mary to figure out, when are we going to interview so-and-so, It's really, it takes a whole team to get that interview in place. And then after the interview, I know that Mary knows the interview has happened. She's already working with that young person. She can circle back around as part of the trauma-informed, because this interview is intense and asks a lot of different questions. And so I know that those kids are already connected to somebody. In terms of the community-embedded approach, we have the LGBT Center, which is a trusted entity for young folks. And it's not just the center that's trusted, it's the people in the center. So Divinity Jones, who has done a lot of outreach and work around HIV, things like that, she is one of the recruiters on this. She's developing a street team of folks that are going to go out and find people and go to transitional housing, go through all those kind of informal networks that DCFS and Connect aren't doing that. Right? So they have the informal networks, same thing with Place for Me, because they're already connected to youth experiencing homelessness. They can go through all of those networks and reach out to the service providers that they know. So it really takes both of those, the informal, community-based, and then the formal system for this study to work. The other thing that we've done to be trauma-informed is, forgot to place that earlier, this is a picture of what one of our setups looks like. And I'm going to just pass these around. I have these. Every interviewer has them. They're like stress balls, right? But they're cuddly and they smell good. And so this is something, and they've been very popular. Some young people don't want them, like some participants aren't interested, but some really, really want these. And they hold them and they squeeze them through the entire interview. And that's a self-regulation tool. Okay, so this is part of the trauma-informed, because we know that some kids are going to get hyper-aroused, and some are going to hyper-arouse, and some are going to shut off. Right? So what are the things that help bring you back when that's happening? And this kind of tactile tool is very simple, but it's one of them. They're so cute, right? Like, so you can look at those. The other thing that we have, participants get paid. Pay is important. They get compensated. They get Visa gift cards. That was important too. It's not like a gift card to a specific place. It had to be a Visa gift card that could be used anywhere. They also get these folders, which I will show you, and I will pass around. The two things I want to show you. There's double-sided coloring markers, and then there is a trauma-informed coloring sheets. This is also a regulation tool. So if you feel after the interview, it may elicit uncomfortable emotions. You may feel agitated. You may feel more anxious. You may feel more hungry. You may feel have different food cravings. But this is something you can do to calm yourself and focus and center yourself. So these are trauma-informed coloring sheets. This one says, I am strong. This one says, I am safe. I'm going to pass these around. So this is something that every participant gets. And so far, the feedback I hear from caseworkers is they really, really like these. I use these all the time, by the way. So I'll pass that around. I have to get these back, though, because I only have 100 of these folders. We're on a budget, so don't take my stuff. The other thing, I have a former foster youth advising me on this study on all levels of it, and what she said was, when I finish something as a foster youth, that's really important. And I'd like a certificate of recognition, so everyone gets that.
How much is the gift card worth?
$40. Excuse me.
That's nice.
Yeah. All right. So that's some of being trauma-informed. Safety, trustworthiness, and transparency. A lot of the questions that I've gotten in the recruitment process so far have been, are you sure no one's going to know my story? Are you sure no one's going to be able to identify me, right? So I go into great detail to talk about that, about how we protect identities. And the other question that I get a lot of is, how is this going to help? Why does this matter? Which I also love that question. So then I talk about how this study is going to be used by DCFS to inform their policies, their practices, that I am passionate about this work. I say I'm family too. I think that's another thing that the interview study team, the majority of folks that are interviewing are also LGBT identified. Actually, all of them are. We're all LGBT identified. And And I talk about how this isn't just a project for me, this is my passion, and that I'm going to work to make this better. And really just having that conversation and transparency has been really important for the buy-in, because the young people have had really hard experiences, and they want that to be recognized, and they want that to be shared in a way that is going to be meaningful and impactful. In terms of peer support, we offer a call out. So we've had at least one participant who's like, I want to make a phone call right now to my support person during the interview, right? So peer support is a key trauma-informed principle, and that's fine. You know, if a young person asks in advance, hey, I want to bring my support person with me in the interview, that's fine. If they want to call someone during the interview, that's fine. You know, I'm not so rigid in my wanting to get quote-unquote pure data or something like that I'm not going to adapt to the needs of the young person, whatever it is that makes them feel safe and supported and secure in this process, and feel that they're owning this process. And I tell my team, too, I say, look, I'd rather have incomplete data and have young people that feel affirmed and in control in this process than have complete data and young people that feel like they've been used. We will not do that. We will not do that. That is not what we do. And that's been really important. The empowerment, voice, and choice as well. There are sections of the interview that are administered by, that are taken by the person themselves, clicking through on the iPad, and there are sections that are administered by the interviewer. The first one I did, the participant did not want to pass the iPad back to me for the interviewer, for the parts where I was supposed to ask the questions. They didn't want to pass it back. They just wanted to keep going on their own. And I said, that's fine, right? That person really needed to be in control of it. Really needed to only be in control of it and not have somebody else coming in. Other young people, it might be the reverse. They want to just answer the questions. So that's an important thing to honor and to follow and to respect. And the cultural, historical, and gender issues, another trauma-informed principle, the language we use, affirming language, inclusive language, use of pronouns from the beginning, introducing ourselves always that way. So those are just some snapshots. I want to talk now about, how am I doing on time, by the way?
It's 12:46. So another 10 minutes.
Okay, I can go through this part quickly-ish. All right, so how do we do affirming, inclusive research in the questions part now? How do we make sure that when we're working with this population, that we're asking questions in a way that are going to be respectful and also get accurate data, right? It's not just about being respectful, it's also about being accurate and actually representing reality in this. So there's the best practice for when you do research, particularly that includes transgender individuals, is a two-step process of asking about sex and gender separately. So they get this question, what was your sex at birth? And they can answer male, female, or intersex if you were born with a mix or variation of male and female anatomy. They get that question. This is what, again, I only got 5 people, right? Like, we've been in the field for 2 weeks, so don't forget. But this is what that looks like when they're asked that question. 2 identified that they were assigned male sex at birth. 3 have identified that they were assigned female sex at birth. Next, they're asked about gender separately. The prompt. There are many words that people use to describe their gender. We have included some definitions of some words that people use. Not all people use these definitions. All pathways are valid. That is affirmative language. That's affirmative phrasing of a question. And then they can check all that apply. This is open, free question. Girl, woman, boy, man, transgender, if your gender is different now than it was at birth. Gender queer or non-binary, if you don't identify with being either a boy, man, or a girl, woman. Gender fluid, if you feel like a mix of both genders and move back and forth between genders, and questioning. So again, they can check as many of these things as they want. When I look at this in the 5 people that have answered, what we see is there's 3 youth that identify as being a girl, woman. There's 1 youth that identifies as a boy, man. There's 3 that identify as transgender, and there's 1 that identifies as gender fluid. And if you look back on that sex part, they're not the same people. Okay? The sex part, there were 2 that were biologically sex male. Those 2 do not identify as men, do not identify as male. There were 3 that I said, yes, I was assigned sex female at birth. And 1 of those does not identify as female. So the point of this is to really show you, if you don't ask these 2 parts separately, you're going to miss folks, right? You're going to miss the people that were born as one thing but don't identify as that thing and don't present as that thing and don't express themselves as that. Does this make sense? So that's why we ask it separately. Also, I have an open-ended question then, because I said, not everyone uses these words. So then there's a question. In your own words, if you would like to tell me in your own words how you identify, someone said, identify as a male, transgender, identify as a woman, as a butterfly. That's my favorite. I think it's beautiful, right? A butterfly. Questions about this?
What is butterfly?
To me, that means metamorphosis. Like if I think about a butterfly, to me what that means is that, you think about how a caterpillar starts as one thing and goes through this process of metamorphosis and change and arises as something else. So I think for that person, butterfly represents their gender because it's like a transformation into something beautiful from something that was started very different. That's what I think. I don't know what they think, but that's how I interpret it. Then I asked separately about sexual orientation. And this is the prompt. This next question is about sexual orientation. Sexual orientation means who you are romantically and physically attracted to. Again, there are many words that people use to describe the sexual orientation. We've included some definitions of some words that people use. Not all people use these definitions. All pathways are valid. And again, they can check all that apply. And then they have a variety of options: lesbian, gay, bisexual, asexual, pansexual, queer, heterosexual, questioning. And here's what this looks like. 5 people. Again, they're checking more than one, right? And I didn't show it here, but after I have this open-ended, check all that apply, I force them to choose the one that's they most identify with. From a research perspective, that's important. But I like to capture both. Everything you identify as, what you most identify as. So we have someone identified lesbian, as gay, as bisexual, as asexual, as pansexual, as queer, and as heterosexual. Isn't this fun? Great. And then we also have, in your own words, how do you identify your sexual orientation? So one person said, I am asexual but panromantic. And another said, I've always felt like I was a woman, which makes me identify myself as heterosexual because I don't feel like I was supposed to be born male. So that's our individual who was born male at birth, identifies as a woman, and a heterosexual woman. Okay, I've got enough time now to show you something else I've adapted. So that piece there shows you how to adapt measures like the measure of sex or gender to be affirmative and culturally appropriate for sexual and gender minorities. I've also had to adapt a lot of measures from the sexual gender minority research world that don't look at foster care. And the big area in that I've adapted is Degeli's victimization measures. So Degeli had one of the seminal NIH-funded studies looking at depression and psychopathology and suicide in lesbian, gay, bisexual youth and young adults, and developed this victimization measure that's been replicated elsewhere, but it doesn't include sources of victimization that foster youth experience. So I, with his permission, further adapted it to include these other sources to be culturally and contextually appropriate for foster youth. So again, this research is adapting in multiple areas. So I didn't show you any of the quantified things. There's a lot of count data for this, but I did want to pull out some of the open-ended because I think it's very striking. So research that looks at just broadly at lesbian, gay, bisexual, transgender youth, not the foster care piece, asks a lot about victimization from like mom, dad, siblings. All right, so these are things like in the national study that we would have seen. Here's some examples of things that our young people have been told by mom, and in this case, mom is biological mother. I hope you die, faggot, with HIV. That I'm a gay-ass bitch, I'm not her daughter, and that she hopes that I die. Everything she say out of her mouth. And the ages, by the way, they were told these things around the age they were told it, and if there's a range, it means I heard this a lot between these age ranges. From dad, that I should be sexually assaulted and kill myself. From my stepfather, I was told that I was a walking disease. From siblings, so I collapsed sisters and brothers to just siblings. Yeah, so many, that I'm a weirdo, that I'm disgusting, that I don't deserve to be around their kids because they'll turn into me. They've told people I have HIV so they won't talk to me, that I was going to hell for being gay, that no matter if I transitioned fully, my chromosomes would still be off. So what I added then were sources specific to foster youth or youth involved in systems. So here are things that foster mom now has said. That I need to pray the gay away because God didn't create me that way. So many foster homes, though. That individual has been in like 22 placements. I don't care what she had to say, which says a lot in of itself. Other kids in the foster home, that they didn't want me there, that they didn't want to sleep in the same room, that I can't hang out with their friends. Faggot, that word used to burn me up. It would make me irately livid. I didn't know how not to let that word bother me. And then among group home or residential staff, which many of our kids we know spend more time in those settings, that my mom doesn't want me because I'm a freak and then I need to stay isolated away from the general population out of the fear that I will touch on them because I'm gay. A staff member told me that I wasn't worth being a man, that I wasn't good enough to be a man. I was also harmed by a staff member, a time where a staff member gave me a razor blade. Staff member was fired. So that's the transgender young man. So, yes, depressing, but so important. There's not another study that I know that is capturing this, right? We know about it anecdotally, we know about it because kids tell us these things, caseworkers tell us things that they've heard, but I have not seen or read a study that is actually capturing these multiple sources of victimization that our kids experience, not just in terms of their biological family, but also in terms of all these system points. And so not in here, but I also have questions about victimization that occurs in juvenile justice settings, other kids in juvenile justice settings, from caseworkers, from foster workers, and yes, there are some quotes. So it's touching on all of those sources that foster system-involved youth may interact with lots of implications for policy and practice, right? So in terms of like my final thoughts, because then I want to make sure I have time for questions, this trauma-informed approach is really, really crucial. And even though we've only done these 5 interviews, knowing that I'm getting referrals and working directly with service providers to recruit young people into the study, and then knowing that they have a connection back out in the community has been really important, because I've had those service providers that I've partnered with call me up 2 days later and be like, yeah, this part was really triggering for so-and-so, but we worked through it and we're doing this, right? So I know that this population has experienced a lot of trauma. I know that reporting on those experiences can relive or re-elicit affective and emotional reactions to it, and therefore being connected with services and supports is so critical. I have a crisis interventionist, Carrie Gibbons, who works for the May Dugan Center, and her number is the first one on here. So when we talk to kids or young folks, and we show them our numbers list, we have all the hotlines and all that stuff, but the importance of being able to say to them, and call this person if you feel distressed at all tomorrow. This is Carrie. I know her. She's family. This is her 24-hour cell phone. She will answer your call. That means so much to have that person on the study team, and that I know that. Because the other thing that's the reality is, I don't know those people at these other service places if they are actually affirming. I'm not going to tell a young person who's trans to call X number and then they experience rejection when they call that number. I need to know that who's picking up the phone knows this study, understands what's going on, is going to be able to direct them appropriately to affirmative care. So that is very, very important. And the team is critical. We have buy-in and support from Cindy Weiskettel, who's the director of DCFS, comes to our meetings. She wrote me letters of support for this research. She knows that I'm doing this.
How did you get them to do that?
I'm a magical unicorn.
I saw that on the first slide.
Yeah. Dr. Prince, magical unicorn. First of all, I was lucky in that when I chose to come here for a faculty position because I knew that the Mandel School had relationships already with DCFS. And so the first summer, like 2 months since I moved here from New Haven, I started going to meetings and things. I was invited to present my research there to Tom Pristo, the former director, very early on. He liked me a lot. We got on. We talked a lot. Then he left. But I was able to transition that over. So having those connections already there was important, and then I'm a magical unicorn. So what else? But also the practice community is engaged in directing the referrals, right? So that's that piece, and I can't underestimate the role of former foster youth themselves in directing the content of this and weighing in. I mean, I had meetings like developing these survey measures and adapting a lot of these survey measures, and then going to the former foster youth who've experienced this and being like, okay, let's talk it through. Let's talk through the language. Let's talk through this. And adapting things and adding things. So I included victimization from religious leaders because former foster youth said you need to add religious leaders. So I did. Right. So there's a lot there as well. Thank you. Okay. Sorry? Oh, the video. I do have a video. I don't know what people want. Do you want a video or do you want questions? I have a 6-minute video of youth who are part of the advisory board for the larger grant talking about pronouns and what they want from the system. 6 minutes. Or you can ask me questions. I don't know. What do you...
I have a question.
Okay, let's do
Is
that.
there a link to the video on the
Let's do
website?
Yeah, we can link in the video.
Yes.
Okay, perfect. We'll do
If
that.
we don't have time today.
Perfect. Okay. Yes.
So my question is, are you working with the LGBTQ to pair up these foster kids with a family?
Yes, that's a great question. So in the larger grant, not this pilot study, but in the larger 4-year grant, a piece of what we're doing is around affirmative caregiving. And it's twofold. One is doing training with current families, providers, an in-depth training about doing affirmative caregiving with LGBTQ youth. And then we're also working on recruiting other families that are affirmative into that circle. And they may be from the community or they may not, because you don't have to be from the community to be affirming. And what's the most important thing is to be able to be in a stable home that is affirming and open. That's the most important thing for our young people. And if they happen to be LGBTQ themselves, that's great, but it's not necessary. But we are doing a lot of work around that area, basically to try and address the issue of placement instability. That's one of the aims of the larger grant. It's how do we reduce placement instability for these kids when they're in the system? So if they're being shuttled back and forth between homes or rejected from homes because started wearing lipstick or whatever it is, that there's a cohort, there's like a group of caregivers, kinship and foster caregiving houses, and therapeutic respite is important too,
Right.
that are trained, that we can say, okay, we know you can go here and you'll be good. And my thing is like, well, can't we put them there before they get rejected? Right? Like, can we figure out the policy identification piece early enough that if we know that that's an issue, we don't have to send that kid somewhere. We can send them directly to one of these affirmative caregiving placements. So there's a lot of systems issues, but yes, that is definitely on board. Do you want to go back in the front?
So I don't know if you have any youth in your study so far that actually have an LGBT care provider or family that at least includes an LGBT member, and what would be the difference, if any? And another question I would have is, what's your control sample?
Great question. So to the first question, I didn't talk about it today, but there's a very long section on social supports, and it's a measure that I adapted from Mark Courtney. If you're familiar with the landscape of youth aging out of foster care research, he is sort of the lead researcher in that area, and he developed this social support measure for foster youth who are transition age that's in the Cal Youth study now. He shared that with me, and I adapted it and added questions about, is that person you're identifying for support LGBTQ themselves? Yes or no, which no one's asked. No, we don't know, right? Like, this is another sort of adaptation that I'm adding in there, is to find out if LGBT young people are identifying LGBT supports in their social support networks. Maybe biological family, may not. And second part of that is, are they out to these support systems that they talk about, right? If they say, oh yeah, foster mom is the person I go to for emotional support, and then it talks about that and it says, oh, is this person you've talked about LGBTQ themselves, yes or no? So we find that out. Then we say, oh, are you out to this person about your sexual orientation or gender identity? If yes, why? Describe, open-ended. If no, why not? Describe. So I'm in the process of collecting that data now. I don't have a control group.
Interesting. Nice.
Oh, it's a wonderful thing to think about. This is a $50,000 pilot study, right? This is a $50,000 pilot study. No, I can publish it without a control group. You know, it's a purposeful sample of SGM youth in foster care. I can publish this without a control group. What I would like to see is, yes, you can say, okay, are there differences for SGM youth then compared to their heterosexual peers in foster care, right? Like that would be the natural sort of next extension of that, and that's why we write R01s. Yeah.
Two quick questions. One, do you find out whether or not kids do reach out for that post, if there's this stress post-interview and you've got this awesome contact person you can reach out to? Do you know if they've used that? I'm just curious.
Yes, because I talk to Carrie all the time.
Okay, and that's not part of your study?
No, but we're tracking everything. I mean, we're tracking
because that's a
everything.
Great sort of piece to include in the research tool. And then
Yep.
I'm just curious if the issue of conversion therapy has come up, which I've just recently learned is still legal in Ohio.
Yes, it is.
Whether or not
it is.
This is sort of being teased out in the research tool.
I don't ask if they've ever experienced conversion therapy directly. There is a set of open-ended questions at the end of the quantitative protocol that talks about like experiences you've had with services and supports, what you would want from a therapist or not want from a therapist, right? So they're open-ended and broad, and if a young person has thoughts on that they can definitely share that, and it may come out more in the qualitative focus groups too. But I'm not asking about it in this. This protocol is already 2.5 hours, 3 hours long, and I've cut out a lot of stuff. Okay. Anything else? You're good? Okay. Thank you.
My mind is just spinning.
Oh, good.
This was really great. Thank you.
Yeah, you're welcome.
So thank you all for coming. We will post this to the PRC's website along with the link to the video that Dr. Prince has from her advisory group, which will be great. I saw a little bit at the beginning of it, and so I think you'll all want to see it. So we'll post that to our website within the week. Right, Susan? Yeah. Tomorrow. Okay, you've heard it from Susan. She's the poster, so that'll be it. Awesome. I also want to just let you all know about our next seminar. There are flyers of the series outside by where you signed in, but our next seminar will be December 14th, which will be a Friday. That's a different day for us. Typically, we're on the second Wednesday. This will be Friday, December 14th. And instead of being here at noon, it will be at the Biomedical Research Building on campus, room 105 at 9 a.m. And we'll be hosting Dr. Maritza Salazar-Campo, who will be talking about team science approaches for translational research. And so I welcome you all to join us there at the BRB, room 105, at the over on. I'm pointing that way because I know it's over that way. To celebrate with Dr. Salazar-Campo. But again, thank you, Dr. Prince, for coming and sharing your wonderful work with us. So.